So this is to again demonstrate the square wave and the sine wave, the rate of rise of the inflation. So the work of breathing in most ventilated babies, we forget about the work of breathing, but remember that if the baby is not synchronized well and the baby is fighting the ventilator, you have increased work of breathing even in ventilated babies. And we don't want to sedate the babies. We'll have a brief discussion tomorrow on sedation, but we don't want to unnecessarily use sedation. You try to synchronize and optimize your ventilation so that, so you're looking at the chest wall retractions in the ventilated baby, you shouldn't really see retractions. If the baby is retracting or working hard, it is telling you something, you need to make some changes. What changes you make, it's not easy to tell you directly because it depends on the condition. It may be secretions, it may be lack of synchrony, it may be inadequate pressure. Nowadays with volume guarantee, you will often see that the delta P comes very low because the volume is achieved. The compliance has improved so fast. So the baby is basically breathing through the ET tube's resistance. The PIP that is delivered is 10 or so and the PEEP is 5 or 6. So your delta P is only 4. So the baby is not adequately supported. Either you increase the tidal volume in those situations or you stop the volume guarantee. You can even switch to SMV with PS in those situations. We'll discuss that as well. So the work of breathing is proportionate to the pressure and volume, and the expiratory work of breathing also may be there if there is resistance. The airway resistance mostly happens from the narrow ET tube. Again, the ET tube choice, if you have intubated with a certain size of ET tube for some reason, if you are going to extubate the baby soon, don't change the tube because the intubation is an invasive procedure and there is a risk to the baby. So only if you need prolonged ventilation or you want to switch to high frequency where optimizing becomes essential, you may consider changing the tube. If you feel the baby can be extubated soon, you can give a trial of extubation and change the tube if it fails. So the work of breathing can be reduced by avoiding a narrow ET tube if possible. Remember that the resistance is proportional to the inverse fourth power of the radius. So the radius matters a lot. So the resistance will change a lot. Adequate PEEP in expiration is important because if your alveoli collapses, to open it up, you need more support. And the lung volume should be optimized. We'll discuss that with the high frequency ventilation as well. Synchronization and the baby cycling as well. Nutrition, I mean, if a baby has very weak chest walls from poor nutrition, wasting, you are going to have increased work of breathing. So you are going to waste more energy as well. So both in a long-term ventilated baby, it matters. And of course, for all reasons, we try to extubate at the earliest possible for BPD rate, for successful non-invasive ventilation.